بسم الله الرحمن الرحيم.
نجعل له عينين ولسانا وشفتين وهديناه النجدين.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه الغر الميامين. أعزائي أبنائي الطلبة، نلتقي بكم مجددا في أول محاضرات الأندرجرادويت ستودنتس في مجال طب وجراحة العيون في سلسلة محاضرات Ophthalmology Made Easy. This lecture is targeting undergraduate students who are in the fourth year medical students, and we will try in a simple way to simplify things to be easy understood by the students, to be able to pass their exam as well as to improve their skills in examining the patients. So I will start with the first lecture about the corneal introduction. In this lecture, we will speak about the brief anatomy of the cornea, the gross anatomy and the microscopic anatomy, as well as we will speak about the physiology of the cornea, and finally we will speak about the pharmacokinetics and the drug absorption through the cornea. I hope that you will enjoy this lecture, and all the links are present at the end of this lecture. For any clarification or questions, you can contact me, and I hope that I will benefit you from this lecture. نتوكل على الله ونقول بسم الله الرحمن الرحيم. The layout of this lecture will concentrate on the gross anatomy of the cornea, as well as the optical property of the cornea, and then we will discuss the histological and the microscopic anatomy, and then we will discuss an important subject, which is the transparency of the cornea and what are the factors responsible for the transparency, and also the mechanism of wound healing in different layers of the cornea. And we will speak briefly about the pump mechanism of the endothelium and the corneal edema. We will speak about the limbus and the different types of limbus, the histological limbus, the anatomical limbus, and the surgical limbus. We will speak about the different corneal incisions, like the clear corneal incisions, anterior limbal incision, mid-limbal incisions, and posterior limbal incisions. And finally, we will speak about the pharmacokinetics and the mechanism of drug absorption through the cornea, and the corneal permeability and the partition coefficient. على بركة الله نتوكل ونتمنى التوفيق للجميع. The cornea is the transparent part of the fibrous coat of the eye. It forms 1/6 of the fibrous coat of the eye. The fibrous coat of the eye is made up of the sclera and the cornea, and the outermost part, the transparent and dome-shaped structure, is known as the cornea. Now, if we go to the gross anatomy of the cornea, you will find that the vertical diameter is around 11 millimeter, and the horizontal diameter is around 12 millimeter. And this can be explained because of the weight of the lid in the vertical direction, so that there is some sort of indentation of the cornea, so that the vertical diameter is less than the horizontal diameter. And this will be responsible for the appearance of with the rule astigmatism, as we will speak about it later on. That's why the vertical diameter is not a fixed or is not used as a reference value. We used to use the horizontal corneal diameter because it is a fixed value. This one is related to the level or the weight of the lid. So if the horizontal corneal diameter is less than 10 millimeter, it is called as microcornea. So microcornea, like this picture, when the horizontal corneal diameter is less than 10 millimeter, this is microcornea. And if the horizontal corneal diameter is more than 13 millimeter, this is called as macrocornea or megalocornea. Now, another thing about the corneal thickness, the corneal thickness is variable based on the location. It is very thin in the center, around 500 microns or half millimeter, and increase as you go toward the limbus to reach to 1 millimeter at the periphery or 1000 micrometers. And the radius of curvature, there are two radii of curvature for the anterior surface of the cornea and the posterior surface of the cornea. The anterior radius of curvature is around 8 millimeter. It is around 7.7, but it is an average 8 millimeter. And the posterior surface of the cornea has a radius of curvature of around 7 millimeter or around 6.6 to 7 millimeter. And the difference in the radii of curvature between the anterior surface of the cornea and the posterior surface of the cornea, this makes the cornea has different powers on the anterior surface as well as the power in the posterior surface. And these powers are different based on the refractive index. So that the anterior surface of the cornea has a positive power around 48 diopter due to the difference in the refractive index between the air and the cornea. However, the posterior surface of the cornea has a negative power because the difference between the refractive index of the cornea and the aqueous. So the cornea acts as a negative, the posterior surface of the cornea acts as a negative meniscus. So as a general, we will speak about the optical properties of the cornea, but what I want you to know that we have two radii of curvature. The anterior surface of the cornea has a radius of curvature larger than the posterior surface of the cornea, so that the cornea power will equal to the power of both the anterior and posterior surface of the cornea. And the nerve supply of the cornea is supplied through the trigeminal nerve, the ophthalmic division, mainly the nasociliary branch. Still in the gross anatomy, as we said that the cornea represent 1/6 of the fibrous coat of the eye, and the fibrous coat is made up of the sclera and the cornea. The junction between the sclera and the cornea is known as the limbus. And later we will speak about the microscopic anatomy and the structure of the limbus. Another point that the curvature of the cornea is different than the radius of curvature of the sclera. That's why when you look to the eye from the lateral side, you will notice that there is protrusion of the cornea as compared to the sclera. So the average radii of curvature of the cornea is around 7 to 9 millimeters. However, the radius of curvature of the sclera is around 11 millimeter. So that this makes the cornea protrude beyond the scleral opening. And another thing that the optical power of the eye is determined by the curvature as well as the refractive index. It is not just only the curvature of the cornea that determines the refractive power of the cornea, but also the refractive index. Now, the difference between the refractive index of the air and the cornea, this will make the rays to converge in certain way to be focused into the retina. Similarly, when the rays are within the cornea and they face the aqueous, the difference in the refractive index between the aqueous and the cornea will make some sort of divergence of the rays so that it will be redirected back again to the cornea, to the retina, so that in total the anterior surface of the cornea is around 48 diopter, the power, and the posterior surface is a negative power, which is around 4 to 5 diopters. In total, the total dioptric power of the cornea will be equal around 48 to 45 diopters. Same thing for the lens, around 16 diopters, so that the total dioptric power of the eye is around 60 diopter. And this dioptric power is a function of both of the radius of curvature as well as the refractive index, either refractive index from the air to the cornea, or from the cornea to the aqueous, or from the aqueous to the lens, or from the lens to the vitreous, and so on. Now, when we speak about the dioptric power of the cornea, as I have spoken before, that we have two important determinants for the dioptric power of the cornea. That's the refractive index as well as the radius of curvature. Now the cornea, we have two surfaces. The anterior surface has a specific radius of curvature, and the posterior surface of the cornea has another radius of curvature. The anterior surface is more flatter than the posterior surface. The posterior surface is more curved because it has a small radius of curvature. Now, according to the Snellen's law, so the anterior surface of the cornea, the dioptric power, will be equal to the difference in the refractive index between the cornea and the air, and this should be divided by the radius of curvature in meters. So the difference between the radius of curvature, the air is a standard radius of curvature, standard refractive index, which is 1, and this is the refractive index of the cornea, which is 1.376. Now, if we divide the difference of this refractive index divided by the radius of curvature in meters, so we will have the anterior dioptric power will equal to 48 diopter. Similarly, if we apply the same principle and the same rule of Snellen's rule on the posterior surface of the cornea, keeping in mind that we will take the refractive index between the cornea and the aqueous now, because the posterior surface here you have an aqueous. So we will measure the power of the posterior surface based on the difference of the refractive index between the aqueous and the cornea. So it will be the aqueous refractive index 1.336, and this is the cornea 1.37. Same thing, we will divide by the radius of curvature of the posterior surface in meters. So you will notice that the posterior surface has a negative power. So the total dioptric power of the cornea will equal to the sum of both the anterior surface as well as the posterior surface. So the net power of the cornea will be 43 diopters. Now there is a question that we used to ask for students, that if you have the air in the anterior chamber, so what will be the net dioptric power of the cornea and what will be the refractive state of the eye? Now, if we apply the same principle, if you have an air in the anterior chamber for whatever reason, so now we'll apply the Snellen's rule. So in the posterior surface of the cornea will become more negative because we will take the difference in the refractive index between the cornea as well as the air here. So the total dioptric power of the posterior surface will be more negative, which is around 9 diopter. So the total dioptric power of the cornea will be reduced, and this will make the patient in the hypermetropic side. That's why a patient with air in the anterior chamber, he notes a glare and not able to see clearly, not only because of the interface of the air, but because of the hypermetropic shift that happens due to change in the dioptric power of the posterior surface of the cornea. Now we will come to this session that we speak about the physiology of the cornea. When we say that we speak about the physiology of the cornea, we mean the different metabolic activity runs in the cornea, and the nutrition of the cornea, from where the nutrition and the source of oxygen and glucose to the cornea. Also, we will speak about the factors responsible for the corneal transparency, and also the endothelial pump mechanism and the mechanism of maintaining the detrussions of the cornea and the mechanism of corneal edema. All these are named under the subject of physiology of the cornea. These are very important topics that should be understood to understand the normal physiology of the cornea. Now, to have a basic understanding of the physiology of the cornea, we have to understand what are the basic functions of the cornea. Now, as we said that the cornea lies in the outermost part of the fibrous coat of the eye, so its main function is a powerful refracting surface. Now, 2/3 of the dioptric power of the eye is concentrated in the cornea. As we said, it is around 45 diopter, which is more than the dioptric power of the lens. So it is an important refractive power or refractive surface of the eye. The second thing, that it is a protecting surface, that it protects the intraocular content. So the cornea should have a particular architecture that firm enough to protect the eye from either mechanical trauma or from toxins and infections. The other thing, that the cornea, through the cornea, it acts as a absorbing surface, that many of the medications and the drops that we are applying to the eye is absorbed through the cornea. So understanding the physiology of the cornea is important to understand the pharmacology and the mechanism of drug absorption and delivery inside the eye. The other thing is that it is a very important structure in the wound repair after the damage to the anterior segment. So understanding the mechanism of repair of the cornea is very important to explain what happens when the cornea is exposed to any type of injuries, either mechanical or physical injury, as well as for any surgical interventions like the LASIK and the PRK, and what happens in the cornea in the form of haze or corneal opacities and so on. And all these functions are met only because of the specific composition of the cornea, that it is mainly made up of water, which is constitute 80% of the content of the cornea is water, and 20% of the weight of the cornea is due to solid materials. Now, the main content of the solid materials is the collagen. Collagen represents 15% of the net weight of the cornea, and mainly type 1 collagen, which represents 50 to 55%. The other is type 6 collagen, is around 25 to 30%. Now, other proteins like the keratin sulfate and the chondroitin sulfate and dermatan sulfate and hyaluronic acid all are important constituents of the cornea. And each one of these components has a role in providing the protection of the eye by providing rigidity to the cornea and providing transparency of the cornea to allow the light to go and get focus in the retina, and also in the permeability of the cornea and the drug absorption. As far as the metabolism and the nutrition of the cornea, as you know, there are rapidly dividing structures within the cornea, like the epithelium. Also, you have an active sodium-potassium pump and different pump mechanisms present in the endothelium. All these activities within the cornea needs a supply of energy, which is mainly through the glucose as well as through the oxygen. The glucose supply comes from the aqueous humor and as well as from the tear film, and also the oxygen supply mainly comes from the tear film, and part of the oxygen is supplied from the aqueous. As you know that the minimum partial pressure of the oxygen present in the tear film is 155, and in the aqueous it is around 40 millimercury. And we need a minimum 25 millimercury partial pressure of oxygen in order to maintain the normal detrussions function of the cornea and the normal endothelium. So the nutrition and the metabolism of the cornea mainly dependent on the glucose in different ways, like the Krebs cycles and the pyruvate cycle. All these lead to the production of ATP, which will provide energy for the different pump mechanisms. Also, it is important for the proliferation of the surface epithelium. Now, the cornea, to perform its job perfectly, to allow for the light to pass perfectly to the retina and get focused there, it has to be a transparent structure. And there are various factors that determines the transparency of the cornea, including anatomical factors and physiological and physical factors. For example, the tear film and the corneal epithelium. Now, the arrangement of the epithelial cells, that they are non-keratinized epithelium and they have a tight junction between the cells, and the cells are homogeneous. This provide a good transparency for the cornea. Also, the presence of the tight junctions that prevent the escape of materials inside the cornea and control the hydration of the cornea. This is very important part to maintain the transparency of the cornea. And also the homogeneity of the refractive index all over the surface of the cornea. This is another important factor. The main cause of the homogeneity and transparency of the cornea is the specific arrangement of the collagen fibers within the stroma and the lamellae. So we will explain about this in the next slide, and the different theories that explains the arrangement of the collagen fibers within the stroma. Another thing, that the corneal vascularization, as you know, the cornea is a vascular structure, and also absence of the lymphatic channels and the blood vessels also contribute to its transparency. And also even the nerves inside the cornea, they lose their myelin sheath once passed through the limbus. So this is another important factors. So these are anatomical factors that contribute to the corneal transparency. However, there is some other physiological factors also contribute to the transparency, which is the corneal detrussions principle that is maintained and governed by the endothelium. Now, the cornea is kept relatively dehydrated, which around 78% only of water within the cornea, and this is very important to maintain the detrusions of the cornea, and this maintain the transparency of the cornea. Also, it is very useful in maintaining the dioptric power of the cornea. So these are some of the factors that contribute to the corneal transparency. As we have said before, that one of the main functions of the stroma is to keep the corneal transparency. And this corneal transparency is related to large extent to the special and peculiar arrangement of the collagen fibers within the stroma. And many attempts are made to explain the transparency theories behind this transparency of the cornea. And there are main two theories that explains this transparency, which is known as the lattice theory or the Mauryk theory. And this theory predominantly relate the corneal transparency to the uniform and lattice arrangement of the collagen fibers. And by lattice arrangement, it means that there is a peculiar fixed uniform shape of the collagen fibers with a fixed diameter of the collagen fibers, which is around 31 nanometer. And the distance between the fibers, that's the interfibrillar spacing, is around 60 nanometer. This ratio is fixed all over the cornea, and this make both the thickness of the collagen fibers and the distance between the collagen fibers less than the half of the wavelength of the visible light, which is around 400 to 700 nanometer. And this will lead to a destructive interference for any scattering rays. So this will lead to high transparency of the cornea. More than 90% of the rays will be passing through the cornea and reaching to the retina. So this is known as the lattice theory or the Mauryk theory. That is, the thickness of the collagen fibers along the interfibrillar distance is less than the half of the wavelength of the visible light. Now, another theory that try to explain that, they say that it is not related to the lattice arrangement of the collagen fibers, but it is mainly dependent into the interfibrillar spacing between these small collagen fibrils. And this small distance is related to minimize the possibility of scattering regardless to the specific arrangement of the collagen fibers. As we have said before, that the stroma made up of lamellae, and the lamellae are made up of bundles, and the bundles are made up of fibers, and the fibers are made up of fibrils. So they relate the transparency of the cornea is related to the distance between these fibrils, not related to the special architecture and arrangement of the collagen fibers, which is explained in the lattice theory. So these are the two main theories that explains the corneal transparency. Of course, there are other causes of corneal transparency apart from this that we will explain later, like the corneal detrusions and also the arrangement of the corneal epithelium. And the avascularity of the cornea also is another reason for the corneal transparency. Also, the absence of myelin sheath around the corneal nerve fibers, all these are related to the corneal transparency. So there are many reasons, but the main reason is the specific and peculiar arrangement, and also the interfibrillar distance between the collagen fibrils that is responsible for destructive interference and prevent the scattering of rays, and hence it will lead to a high degree of transparency of the cornea. Still in the context of the corneal transparency, after we finish the anatomical factors that are responsible for the corneal transparency, there are other physiological factors that mainly based on the keeping the detrusion state of the cornea that help in the transparency of the cornea. And one of these physiological factors is the, as I said, the barrier function of the epithelium and the endothelium. Now we have a tight junction at the apical part of the epithelium as well as in the endothelium. So it will limit the infusion of fluids from the tear film or from the aqueous fluid inside the cornea. So this is very important in the corneal transparency. And we have different types of endothelial pump mechanisms. We will speak about them later, but just to mention them here: sodium potassium ATPase pump system, a bicarbonate pump system, and the sodium hydrogen pump system. All these are available in the endothelial based membrane and the endothelial cells to keep the corneal dehydration. Also, the evaporation from the corneal surface and the normal IOP of the intraocular, that's the intraocular pressure. Also, this useful in keeping the transparency of the cornea, as you know that in cases of high glaucoma with high intraocular pressure, the cornea will be edematous and will be cloudy. Also, the swelling pressure within the stroma, that there is intrastromal pressure that counteract the impipation pressure that will suck the water inside the stroma. So also the presence of corneal crystalline. This crystalline is specific proteins present within the keratocytes in the stroma, and these proteins are homogeneous and useful in keeping the transparency of the stroma and prevent the reflection and the scattering of light. That's why it is very important contributor to the transparency of the cornea. Apart from the collagen distribution, also the presence of this crystalline proteins within the keratocytes plays an important role in the corneal transparency. Now, if we look in details about the physiology of the corneal endothelium per se, because the corneal endothelium is very important structure that maintain the corneal detrussions through the bump leak hypothesis, in which there is a dual function of the corneal endothelium. It allows for the leakage of the solutes and nutrients from the aqueous towards the layers of the cornea, as well as it pumps the water actively or passively from the cornea towards the aqueous. So this plays an important role in the nutrition of the cornea as well as maintaining the detrussions of the cornea. And this transport system is carried out by different pump systems like the sodium potassium pump as well as the carbonic anhydrase pump system, because the corneal endothelium is rich in the mitochondria, and this makes the consumption of oxygen within the endothelium is 5 to 6 times more than the epithelium, because of the very rapid and highly active pump system available within the endothelial cells. And when there is a very high intraocular pressure, this will more than 50 millimercury, this will paralyze and stop the sodium potassium pump system, and that's why the patient will end up by corneal edema. In the next slides, we'll explain in details about these pump systems and how they work to keep the cornea as dry as possible. Now, to understand how the cornea maintains its detrussions and relative dehydration state, we have to understand the mechanism of influx and efflux of fluids from and out of the cornea based on the pump mechanism which is present in the endothelial side of the corneal structures. Now we have two main pump mechanisms, which is known as the metabolic pumps. That's the sodium potassium pump, ATPase system, present in the basolateral side of the endothelial cells. And these pump mechanism will pump the sodium toward the aqueous, and by this way it creates an oncotic pressure, so that the water will drawn from the stroma down this oncotic pressure towards the aqueous. So it is indirect way by pumping the sodium toward the aqueous. This will create an oncotic pressure and osmotic gradient that it will draws the water from the stroma toward the aqueous. The other pump mechanism is the carbonic anhydrase pump. It is present within the cells itself of the endothelial cells, And the same thing, this is an active transport that actively transports the bicarbonates into the aqueous humor. And by this way, it creates a negative electrical charges within the aqueous humor. And this will draws the positively charged ions from the stroma, and along with it the water out of the stroma toward the aqueous. So this is called electroosmosis, by creating an electrical gradient. However, the sodium-potassium pump creating an osmotic gradient. So there are two ways: osmotic gradient by the sodium-potassium pump system, and the electrical osmotic gradient by the carbonic anhydrase pump system. Now, another thing that there are other powers playing a role within the stroma, that we have what's known as the impipation pressure. Now, the impipation pressure is the ability of the stroma to suck the water from the aqueous towards the stroma, and this is because of the presence of the glucose aminoglycans and the ground substance, which is negatively charged. This creates a repulsion between the molecules of this substance, and this will attract the water from the aqueous toward the stroma. This is called the impipation pressure. Now, this impipation pressure is counteracted by the presence of what's known as the swelling pressure within the stroma, because these two forces are acting to draw the water or the aqueous from the anterior chamber towards the stroma. The intraocular pressures plays an important role to draw the aqueous toward the stroma, and the impipation pressure also will draw the aqueous toward the stroma. Now, this will create a swelling pressure within the stroma that counteract these two forces. So the impipation pressure is the difference between the swelling pressure here, which is around 60 millimercury, and the intraocular pressure. So the impipation pressure is a negative pressure because it is a suction pressure. So if the pressure here is 60 millimercury and the pressure intraocular pressure is 20, so the difference between the intraocular pressure and the swelling pressure will be minus 40. Now, this minus 40 is the suction pressure that will make the stroma or draw the aqueous toward the stroma. Now, this explains also why in state of corneal edema, increasing the intraocular pressure will lead to corneal edema, because the negativity of the impipation pressure will be decreased. When the IOP is now, for example, it is 30, so we subtract the 30 from the 60, it will be minus 30. Before it was minus 40. So when the negativity decrease, indicate that the impipation pressure increase, so that there will be corneal edema. So this is another factor that plays a role in the determining the hydration and the intrusions of the corneal tissues. Now we, after finished the gross anatomy of the cornea, we come to the important aspect, that's the microscopic anatomy of the cornea, namely the histology of the cornea. This part of the lecture is very important, because in our traditional teaching for the 4th year, we used to say that the cornea is made up of 5 layers. However, recently with the introduction of the new layer made by Herminder Dua, that's the Dua's layer 2013, now the cornea is made up of 6 layers. So for you as undergraduate students, if you say that the cornea is made up of 5 layers, is accepted. But also for brilliant student and excellent student, if you say that the cornea is made up of 6 layers, and you're able to mention the name of that layer and the difference of that layer from the other layers, will be very good and very excellent. So we will dive deeply and go to the histological structures of the cornea. Now let's come to the microscopic anatomy of the cornea. We finished the gross anatomy. Now the microscopic anatomy refers to as the histological structure of the cornea. In our traditional teaching for 4th year students, we used to say that the cornea is made up of 5 layers. That's the epithelium layer, which is the anterior epithelium, and the Bowman's layer, and the corneal stroma, and the Descemet's layer, and the endothelium. However, recently another 6th layer has been found here in this area, which is known as the pre-Descemet's layers or the Dua's layer. But for you as students, if you say the cornea is 5 layers, is accepted. If you say it is a 6th layer, also it is accepted, provided you name the name of this layer, which is the Dua's layer or the pre-Descemet's layer. And for as a mnemonics, you have to memorize the 5 layers as this: A for anterior epithelium, B as a Bowman's membrane, C as a corneal stroma, D Dismus membrane, and E for the endothelium. Now, in the next slides, we'll speak about each layer in details. We will start with the epithelium, and we will speak about the features of each layer and what are the function of each of these layers and the composition of each layer. Now, the first layer of the cornea is the corneal epithelium, and the corneal epithelium represents around 50 to 90 micrometers, and it is made up of mainly of three types of cells, but 4 to 5 layers of cells. The single layer of cells, which is the basal layer from below, and sit on a basement membrane and attached to this basement membrane by a hemidesmosomes. This is a columnar cells sitting as palisades in a vertical manner, and then followed by another 2 to 3 rows of wing cells in the intermediate zone. And the last layer is the superficial epithelium, which is made up of 2 to 3 layers also, covered by microplica to increase the surface area, as well as to be invaginated in the tear film. And this layer of cells has a very rapid regenerative ability to compensate for any damage or any abrasions, and represent the anatomical barrier as a very tight occlusions, zona occludens, and the desmosomes is attached between the cells, so it make a barrier for the diffusion of the tear film inside the cornea, as well as this is important barrier for the drugs when are placed into the cornea. So this is the main 5 or 6 layers of the epithelium, but we have 3 types of cells: the columnar cells, the wing cells, and the superficial cells. Now, I should remember here that all the layers of the cornea are derived from the paraxial mesoderm, except the corneal epithelium, which is derived from the surface ectoderm. Now, you should memorize this and remember this, that the surface epithelium is derived from the surface ectoderm. However, the remaining layers of the cornea, that's the stroma and the dismus and the endothelium, is derived from the mesoderm. If we go in more detail and look to the details of the microscopic anatomy of the epithelial layer, and we concentrate in the superficial most layer, which is made up of 2 to 3 layers, which is namely the stratified squamous non-keratinized epithelium, which is polygonal in shape. These cells are tightly packed together and attached by desmosomes and by zona occludens, and the outer surface is covered by microvilli and microplica that's anchored in the mucous layer of the tear film, forming what's known as a glycocalyx. Now, this tight junction between cells make a barrier against toxins, bacteria, and for the diffusion of the tear film inside the cornea. So it helps to prevent the dehydration as well as over influx of water inside the cornea. And also, it is a very important anatomical barrier against toxins and microbes that invade inside the cornea. So this layer, this is the superficial layer. It is stratified squamous in shape, and it is tightly packed 3 to 4 layers. Now, the other important layer of the surface epithelium is the basal layer. Now, the basal layer is a single layer. It is not multiple layers. It is a single layer. It has a columnar shape in appearance, and it is a single layer sitting on a basement membrane. This basement membrane is made up of 2 layers. The one towards the epithelium is known as lamina lucida, which is about 25 millimeter thickness, and the one which is towards the Bowman's membrane is known as lamina densa, which is about 50 nanometers in thickness. And this layer is the importance of this layer, that it has a rapid mitotic activity, so that it replaces the defect in the surface epithelium and into the wing cells in the intermediately. It plays an important role in the wound healing. So whenever there is any damage to the surface epithelium, so that the replacement will come from the basal layer, provided that the basement membrane is intact. Now, the lifespan for the cells is around 7 days to replace or to migrate the cells from the basal layer, the columnar layer, to the surface epithelium. However, if the basal lamina is involved or damaged, so you need 6 to 7 weeks to replace the surface epithelium. So the basal lamina here is very important. And this basal lamina is anchoring the basal columnar cells to the Bowman's membrane by hemidesmosomes. So abnormality in this layer plays an important role in occurrence of some diseases like the recurrent corneal erosion syndromes and will lead to persistent epithelial defect. So to sum up, that this layer plays an important role in the mitotic activity, and it will replace the wing cells and the epithelial cells, and it is a single layer attached to the basal lamina, and the basal lamina is attached to the Bowman's layer by hemidesmosomes. Now, when we look to the structure of the basement membrane by electron microscopy, there is an important clinically applied informations that should be understood very clearly. When we look to the basement membrane, that is the layer below the basal layer, by electron microscopy, we divide it into lamina lucida, which is a electron lucid layer, or lamina densa, which is the electron dense layer, which is below towards the Bowman's layer, and the reticular layer or lucida reticularis, which is anchoring the basement membrane towards the Bowman's layer. As I have said before, that the intercellular attachments is there is desmosomes, and the hemidesmosomes are between the basal layer and the basement membrane is a hemidesmosomes. However, intercellular attachment is known as desmosomes. Now, when we look by electron microscopy, you can see that the lamina lucida is made up of the hemidesmosomes that's attaching the basal layer to the basement membrane, along with an anchoring fibrils. This is the lamina lucida that's seen by electron microscopy as electron lucid layer. Now, another thing is the basement membrane is made up of two layers. That is the electron dense area, which is called lamina densa, and another anchoring fibrils that is anchoring the basement membrane towards the Bowman's layer. Now, it's important here to know that when there is a recurrent corneal erosions, which is a problem that can happen due to trauma or due to dystrophy in the basement membrane. Now, in the traumatic recurrent corneal erosions, the hemidesmosomes are intact, and usually the problem here in the anchoring fibrils between the basement membrane and the Bowman's layer. This is in traumatic recurrent corneal erosions. However, when there is a basement membrane dystrophy, the recurrent corneal erosions will happen because of the damage in this area, which is the hemidesmosomes are not formed and the basement membrane is not normal. So there will be sloughing of the epithelium because of the damage in the basement membrane itself. That's why it's called a epithelial basement membrane dystrophy. However, in traumatic recurrent corneal erosions, usually there is no dystrophy of the basement membrane, and all these layers are normal. The problem here in the anchoring fibrils between the basement membrane and the Bowman's layer. This should be understood very clear. Now, to understand the normal cell cycle and the transition of the cells from the basal layer up to the epithelial layer and end up by shedding at the superficial layer to the tear film, we should speak about the limbal stem cells and about the limbus. Now, the limbal stem cells are present in the basal epithelium in the form of crypts or palisades, known as palisades of Vogel's. And these crypts are much more in the inferior limbus as compared to the superior limbus. Now, these cells represent a pluripotent cells that capable for differentiation. They are undifferentiated pluripotent cells that capable for differentiation upon stimulation. Now, the stimulus for this differentiation can be either a normal natural stimulus for differentiation based on the amount of corneal epithelial shedding that happens every day, or in response to any corneal injury that lead to release of certain mediators and growth factors that stimulate this undifferentiated pluripotent cells to be migrate and proliferate and compensate for any defect present. Now, if we go on details and see more in this cryptus, you will find that it is made of this is the crypts, and this is the corneal side, the corneal epithelium, and this is the limbus. And each stem cells present in the limbus will divide into a daughter cells and into a transient amplifying cell upon stimulation. Now, that's why the normal population of the stem cells will not be affected, because its stem cells is divided into a daughter stem cells exact character, and then another cells which is a transient amplifying cells. This is still not a differentiated cells, but it is capable of proliferation and amplification. Now, upon stimulation, this transient amplifying cells will be have a rapid mitotic activity, and they will have a centripetal movement within the layers of the epithelium. So they will migrate from the basal layer to the wing layer and then to the epithelial layer. And at the end, will have a terminal differentiation. Now, at this level, it will be terminally differentiated to epithelial cells. And of course, as a part of the cell cycle, later on, it will be shed to the tear film. This is the normal cell cycle that happens to the epithelium, starting from the limbus and end up to the surface epithelium. After understanding the cell cycle and the role of the stem cells, so to summarize the stages of corneal healing or response to any injury or the normal cell cycle, it has three stages: a latent phase or latent stage, which is from the time of insult, take 4 to 6 hours, and at this stage the release of mediators and the growth factors will be initiated. Then the cell migration from the limbal stem cells, they will migrate toward the basal layer of the epithelium, and then they differentiate to or proliferate to amplifying cells, as I said before. And these amplifying cells will continue to proliferate and migrate centripetally in the corneal epithelium till it reaches to the surface epithelium and undergoes a final differentiation. And after the differentiation, there tight junctions will be created between cells and adhesion of the cells, so that the cell will be stable, and this will terminate the cell cycle. So the cell will propagate from the basal layer to the wing layer to the apical cells. Then another shedding will happen to the cells at the tear film, and the same cell cycle will be initiated. So this is the normal cell cycle, as I said, as a normal response or as a response to any corneal injury. And I would like to speak about the principle which is known as the XYZ hypothesis for the corneal epithelial proliferation, that X stands for the proliferation of the basal cells, and the Z refers to the shedding of the cells or the cell loss from the surface, and the Y refers to the centripetal movement of the cells. Now, the principle says that for the equilibrium of the corneal epithelium to happen, the amount of proliferation of the epithelial cells should equal to the amount of shedding of the epithelial cells. So this is known as the XYZ hypothesis, in which X stands for the proliferation, Y for the migration, and the Z for the shedding of the epithelium. So the shedding of the epithelium should equal to the amount of the proliferation plus the amount of movement or centripetal movement of the epithelium within the corneal epithelium. Before finishing speaking about the corneal epithelium, I would like to add some important clinically applied anatomy, that in the presence of vitamin A deficiency, the corneal epithelium will be keratinized, and it will lose its luster, and it will be hazy like this in this picture, because it becomes keratinized. Normally, as you know, the corneal epithelium is stratified squamous non-keratinized epithelium, and of course this keratinization is will herald later on vascularization and neovascularization of the cornea, and the whole anatomy of the cornea will be disturbed. So vitamin A is very important in the health of the corneal epithelium. Another thing is the Fleischer's ring, which is commonly seen in keratoconus cases, which is due to pigmentation, will be found in the basal epithelial layer. Now, this pigmentation will be present at the level of the basal epithelial layer, commonly seen in a Fleischer's in keratoconus, known as the Fleischer's ring. It is a brown to yellow ring, which may be complete or incomplete. This is just I would like to add before I finish this talk about the epithelium, and this is the Fleischer's ring. Now we come to the second corneal layer, which is the Bowman's layer. It measures about 8 to 14 micrometer. It lies below the corneal epithelium from outside. And it is not a real membrane or a basement membrane. It is just a condensation of the collagen fibers from the outer stroma and is secreted by keratocytes. And it is acellular layer, not elastic, characterized by tough and has mechanical protection for the cornea. And it lacks regeneration because no fibroblast. So upon damage, it will be replaced by fibrous tissue. Also, the Bowman's layer has another important function, which is act as a anchoring substance that anchor the epithelium to the underlying stroma, and so that it maintains the stability. Also, as I said, that it is acellular and tough structure, so it provides a mechanical support to the cornea. And another thing that it prevents the stromal keratocytes from being exposed to the epithelial growth factors. As I said before, that the epithelials has a rapid mitotic activity and a lot of growth factors are secreted at that area. So the Bowman's layer acts as a barrier to prevent the diffusion of these growth factors to the underlying stroma and prevent the metaplasia of the keratocytes and fibroblasts. So Bowman's layer has mainly a support as a mechanical support and as a barrier to prevent the diffusion of growth factors to the underlying stroma. The third important layer of the cornea is the corneal stroma or the lamellar stroma. This is constitute the main bulk of the cornea. Around 90% of the thickness of the cornea is made up of the stroma, which is around 0.5 millimeter. And this corneal stroma plays an important role in keeping the corneal transparency. As you will see that the peculiar arrangement of the collagen or the corneal lamellae in the stroma at a right angle to each other, this is very important to keep the corneal transparency, that we will explain it later on. And these lamellae of the stroma, which is around 200 lamellae, are made up of bundles of collagen, around 200 to 300 bundles of the collagens. And these bundles of the collagens are much more in the periphery as compared to the center. However, you will see in the next slides that the packing of the collagen is more in the center as compared to the periphery, because the center, as you know, has a little thickness as compared to the periphery. So to keep the shape and potentiate the central part of the cornea, so the packing of the collagen fibers along with the ground substances is much more in the peripupillary area as compared to the periphery. Another thing we will explain the next slides, that the types of collagen fibers differs in the anterior 1/3 of the stroma as compared to the posterior 2/3 of the stroma. As we have said before, that the packing density of the collagen fibrils or lamellae in the anterior 1/3 of the stroma is much more than the posterior 2/3 of the stroma. So the packing density here is much more as compared to the posterior part of the stroma. And this makes the anterior 1/3 of the stroma is more stiff as compared to the posterior 2/3. And that's why this is very important clinically applied finding, that in people or surgeons who are doing LASIK surgery, they should know this fact, that when they do the LASIK flap, they are doing it in the stiff 1/3 of the cornea. And when you are planning to do cross-linking, the effect of cross-linking should be here in the posterior 2/3 of the stroma, where the stiffness and the packing is less than as compared to the anterior 1/3. And this might also explains that in keratoconus, the bulging of the cornea is because of the defect that happens in the posterior 2/3 of the cornea, as the packing and the density of this area is less as compared to the anterior 1/3 of the stroma. Another thing, that the collagen fibrils in the peripupillary area is much more than in the peripheral part of the cornea. And this is to counteract the decrease of the thickness of the cornea in that area. You know that the central cornea is more thin as compared to the peripheral cornea. And to maintain the stiffness of the cornea and the shape of the cornea and at that area, the peripupillary area, that's the area surrounding the pupil, and the area in the optical zone should be densely packed with collagen fibrils and ground substance, so that it keeps proportional stiffness of the cornea at that area. Another fact that even the distribution of the ground substances and the proteoglycans has special impact also on the stiffness of the cornea, as the anterior 1/3 of the cornea has predominantly chondroitin sulfate as compared to the posterior 2/3, which are predominantly keratin sulfate. So the chondroitin sulfate and the dermatin sulfate are more predominant in the anterior part of the stroma. However, the keratin sulfate is predominantly in the posterior part of the stroma, and this also explains why the anterior part is more stiff as compared to the posterior part of the stroma. To summarize that what we have said before, that the composition of the stroma is mainly of keratocytes and extracellular matrix. The extracellular matrix made up of collagen type 1, type 3, 5, 6, and 12, and also the ground substances, which is the keratin sulfate, chondroitin sulfate, and dermatin sulfate. Now, another important point that there is type 6 collagen, which is mainly present in the anterior stroma, which is responsible for the intertwining between fibrils of the or the bundles of the collagen, is predominantly present in the anterior stroma, and this also might explain the stiffness of the anterior part of the stroma. So the anterior part of the stroma has predominantly type 6 collagen, which is responsible for the interwind between the collagen fibers, and that's why the anterior part is more stiff than the posterior part. As we have said before, that one of the main functions of the stroma is to keep the corneal transparency. And this corneal transparency is related to large extent to the special and peculiar arrangement of the collagen fibers within the stroma. And many attempts are made to explain the transparency theories behind this transparency of the cornea, and there are main two theories that explains this transparency, which is known as the lattice theory or the Mauryk theory. And this theory predominantly relate the corneal transparency to the uniform and lattice arrangement of the collagen fibers. And by lattice arrangement, it means that there is a peculiar fixed uniform shape of the collagen fibers with a fixed diameter of the collagen fibers, which is around 31 nanometer, and the distance between the fibers, that's the interfibrillar spacing, is around 60 nanometer. This ratio is fixed all over the cornea, and this make both the thickness of the collagen fibers and the distance between the collagen fibers less than the half of the wavelength of the visible light, which is around 400 to 700 nanometer. And this will lead to a destructive interference for any scattering rays. So this will lead to high transparency of the cornea. More than 90% of the rays will be passing through the cornea and reaching to the retina. So this is known as the lattice theory or the Mauryk theory. That is, the thickness of the collagen fibers along the interfibrillar distance is less than the half of the wavelength of the visible light. Now, another theory that try to explain that, they say that it is not related to the lattice arrangement of the collagen fibers, but it is mainly dependent into the interfibrillar spacing between these small collagen fibrils. And this small distance is related to minimize the possibility of scattering regardless to the specific arrangement of the collagen fibers. As we have said before, that the stroma made up of lamellae, and the lamellae are made up of bundles, and the bundles are made up of fibers, and the fibers are made up of fibrils. So they relate the transparency of the cornea is related to the distance between these fibrils, not related to the special architecture and arrangement of the collagen fibers, which is explained in the lattice theory. So these are the two main theories that explains the corneal transparency. Of course, there are other causes of corneal transparency apart from this that we will explain later, like the corneal intrusions and also the arrangement of the corneal epithelium, and the avascularity of the cornea also is another reason for the corneal transparency. Also, the absence of myelin sheath around the corneal nerve fibers, all these are related to the corneal transparency. So there are many reasons, but the main reason is the specific and peculiar arrangement and also the interfibrillar distance between the collagen fibrils that is responsible for destructive interference and prevent the scattering of rays, and hence it will lead to a high degree of transparency of the cornea. Now we come to an important issue, which is the stromal wound healing. What's the response of the stroma upon damage or toxins reaching to the stroma? So what will be the response? As I have said before, that the stroma is made mainly of the collagen fibers, the glucosaminoglycans or the ground substance, and also the keratocytes. Now, the keratocytes plays an important role in this stromal wound healing. Now, when there is any inflammations or any defect in the corneal epithelium or toxins with a concurrent damage to the Bowman's layer, now the toxins and the mediators of the inflammation will reach to the stroma, and this will activate a cascade way of activation that it activate the keratocytes to be transformed to fibroblast, and then this fibroblast will be converted to the myofibroblast. And also there will be a release of certain growth factors and other mediators of the inflammations that lead to also changes in the ground substance and production of abnormal proteins that will lead to eventually into the haze. That the haze that you see in the stroma is related to the abnormal extracellular matrix and abnormal proteins that is secreted upon inflammations. Also, the myofibroblast responsible for the remodeling of the stroma and the fibrosis that happens after the inflammation, also the irregularities and the haphazard arrangement of the collagen fibers that will happen after the inflammations or the damage that happens to the stroma. So this is generally the stromal wound healing is guided and predominantly guided by the keratocytes and is induced by mediators of the inflammation when the toxins are reaching to the stroma. Now the fourth layer after the stroma is known as the Duas layer, and this layer is related or to the doctor who discovered this layer, whose name is Herminder Dua at 2013. He's from the University of Nottingham. He's an Indian ophthalmologist, and this layer is around 15 microns in thickness, a very thin layer, lies in front of the Descemet's layer. And although it is very thin, but it is very strong and impervious to air, and it contains no keratocytes. Now, the discovery of this layer has led to the description of different types of keratoblastis in the posterior segment of the cornea, namely the predescemet endothelial keratoblasty and the DALK, the deep anterior lamellar keratoblasty. Now, also this layer has differentiated between the bubbles that is created during the DALK procedure. So we can classify the bubbles as type 1 and type 2 based on the level of this bubble. If the bubble lies between the Duas layer and the stroma, this is called type 1. And if it lies between the Duas layer and the Descemet's membrane, this is called type 2. Now, most doctors, they prefer type 1 of the bubbles that lies here between the Duas layer and the stroma, as it is usually confined in the central part of the cornea, and the risk of perforation of the Duas layer is less, as it is very tough and tight. Usually this type of bubble is seen in 70 to 80% of the times. However, in the type 2, the bubble will extend up to the periphery of the near to the limbus, and the risk of perforation is more, and usually seen in 20 to 30% of the time. Now, another thing that the discovery of the Duas layer has led to the description of what's known as predesmetocele or duocele. in comparison to the dysmetocele. As you know that when there is severe melting of the cornea and bulging of the dysmus layer, this is called dysmetocele. However, if there is thinning of the anterior part of the cornea and bulging of the duous layer, this is called predysmetocele and also known as the duocele. Now, the clinical significance of this differentiation is that the predysmetocele or the duocele is usually related to the infectious diseases, and usually the surface is rough and some epithelial, you'll find some epithelial cover, and the chance of perforation is less and the bulging is less, as compared to the dysmetocele, which is usually due to autoimmune disease, in which thinning and melting of all these layers of the cornea, and the risk of perforation is more and the bulging is more, and you will hardly see any epithelium because it is shining membrane, the dysmus membrane shining and very clear, so you will not find any epithelial cells. So this differentiation between the dysmetocele and the predysmetocele is due to the discovery of this layer. So if you can see the duocele, the risk of infection, the risk of perforation is less. However, the dysmetocele, the risk of perforation is more. Now, the fifth layer after the duous layer is the dysmus membrane. Now, the dysmus membrane is around average thickness around 7 micrometers and made up of mainly type 4 collagen and laminin. And the formation usually starts within the intrauterine life, so that at birth there is around 3 micrometer thickness, and it increases the thickness as the child or the patient grows on, so that in adult it can reach up to 10 micrometer in thickness, and it is mainly made up of collagen type 4 and it is and laminin, and it is very resistant to the chemical and toxins due to the infections, and it is capable of regeneration. This is the advantage of this membrane, that is capable of regeneration, and it is very elastic and resistant to toxins and diffusion of toxins inside the eye. Now, the other feature of the dysmus membrane, that it has two components: an intrauterine component, which is the anterior part, which is mainly around 3 millimeter at birth, and it continues to be secreted and produced. So the posterior part is the one which is formed after the delivery. So at birth around 3 to 4 microns, at childhood around 5 microns, and at adulthood reaching up to 12 micrometer in thickness. So this is the main features of the dysmus membrane, and it is capable of regeneration. Now we come to the sixth layer of the cornea, which is the corneal endothelium. This is very important layer that lies posterior to the dysmus membrane, and this layer is derived from the neural crest, and this make it incapable of regeneration. So this layer is very precious layer. It is a single layer of polygonal cells that attach to the dysmus membrane by a hemidesmosomes, and there's tight junctions and gap junctions between the cells, and an active pump mechanism so that it maintains the corneal detrussions, and the corneal hydration is maintained through this layer. So this endothelium is very important to maintaining the corneal thickness and the corneal hydration. At birth, we born with around 6,000 cells, and there is an annual decay rate, so that by annual decay of around 0.6%, so that at old age we reach up to 2,000 cells per square millimeter, and a minimum 800 cells per square millimeter are needed to keep the corneal detrussions and corneal dehydration. This endothelial cells that I have mentioned before, that derived from the paraaxial mesoderm, namely from the neural crest, make it not able to regenerate, and so that this layer of cells is very precious, and once damaged, there will be no regeneration, but there will be change in the shape and the configuration of the cells to overcome the gaps within the row of cells. Now, these cells on birth, we have around 10 micrometers thickness, these cells, and as we grow up, it will continue to flatten to become around 4 micrometer in thickness, and it has a honeycomb appearance or mosaic pattern, the shape as seen by specular microscopy. And as I said, the main function is to maintain the corneal detrussions and control actively the sodium-potassium pump and the hydration of the cornea. The problem that this layer is not able to regenerate, and once damaged, when the number reaches below a critical limit, there will be some sort of corneal decompensation, and there will be a loss of corneal transparency and hydration of the cornea because of damage of this layer. So this layer is very precious layer and very important to keep watching this layer, especially during phaco emulsification, as damage of this layer will not be able to regenerate it. Now, as far as we are speaking about the endothelial cell layer, I would like to choose this opportunity to speak a little bit about how we measure or assess the endothelial cell layer using what's known as the specular microscopy. The specular microscopy is the by which we can assess the endothelial cells quantitatively as well as qualitatively. Now, as far as the quantity, now there are various parameters we measure during the specular microscopy. For example, the cell density. Now, the cell density reflects the number of cells per square millimeter. And this number of cells, as we mentioned before, at birth is around 3,000 cells per square millimeter, and decrease as we grow up. And the minimum amount needed to maintain a normal function of the cornea is 800 cells per square millimeter. But this is not the only variable or factor that determine the health of the endothelium. The cell number is not enough parameter to have an idea about the health of the cells. Another variable is the hexagonality percentage. Now, as we said, that the normal shape of the endothelium is hexagonal in shape, and the percentage of hexagonality should be more than 60 to 70%. Now, if it is less than 60%, it indicates abnormality and indicate polymorphism, because when the hexagonality decrease, so there will be many abnormal shapes, and this will be named as polymorphism. Another thing is the mean cell area, another parameter that we evaluate during the specular microscopy printout. And the most sensitive parameter is the coefficient of variation of cell area. Now, this coefficient of variation normally between 0.2 to 0.3. Some printout says 20% to 30%. So now, the more this coefficient of variation, the more is the variation in the cell size, and so this is named as polymegathism. If it is more than 0.3, so indicate that there is a polymegathism. And as you know, as we said before, that the endothelial cell layer is not capable for multiplication. So any defect or any damage in the endothelial cells, it will be replaced by increase in the cell size, as well as increase the thickness and increase in the shape, and different shapes will appear as a result. So the polymorphism and polymegathism is a reflection of the healing process that takes place during endothelial injury. When there is any endothelial injury, the healing process will take the shape of polymorphism and polymegathism. Polymorphism indicate that the hexagonality is less than 60%, and the coefficient of variation indicate that the polymegathism is more than 30% or 0.3. These are the main variables or the main factors that we study in the printout of the specular microscopy, which is used to assess the endothelial cell function, as well as the anatomy and the integrity of the endothelial cells. In this slide, I will show you the normal shape of the endothelial cells, which is hexagonal in shape, that has 6 borders and 6 faces. So this is the normal appearance of the endothelial cells, which is the hexagonal pattern. This mosaic pattern and hexagonal pattern is disturbed whenever there is damage to the endothelium. So the healing process will start, and the healing process in the endothelium, because it is not capable of multiplication, it will be reflected by changes in the cell size. This is known as polymegathism, and changes in the cell shape, which is called as polymorphism. And as you can see here, that there is different increase in the size and different shapes of the endothelium. And this is a real picture from endothelial or specular microscopy, that you can see the different shapes of the endothelium cells and different sizes. So this is a combination of polymorphism and polymorphism. Similarly, this is another picture from the specular microscopy. This is the normal epithelium, or the normal endothelium, I mean. And you can see the cell density and the shapes are hexagonal in shapes, and with the high cell density. Now, this is decrease. When there is decrease in the cell density, now the cells will expand and will have abnormal shapes and abnormal sizes, reflected by this is the polymorphism and polymorphism. This black dot, this is just a abnormal collagen formation within the endothelial cells. As you know, the function of the endothelial cells, apart from maintaining the detrussions of the cornea and determine the balance of the hydration of the stroma, also it produces a collagen that forms the desmus membrane, that's the basement membrane of the endothelium. When there is abnormal endothelial functions, or the endothelial under stress, so there will be abnormal collagen formation, which is localized within the endothelium, and this will appear in the specular microscopy as this black dots, which is indicate that these cells are under stress. Similarly here, the endothelial cell, you can see different shapes of the endothelial cells, small sizes and big sizes, and this is an end stage in which there is advanced damage of the endothelium with a lot of black dots. This is stage 3 gut data, and we will explain about this later on. So this is just to show you that the abnormal shapes of the endothelium when there is any healing process or any damage to the endothelium. This slide shows the printout of the specular microscopy and the important informations that we should concentrate on. As I mentioned before, one of the main important is that the number of cells. Now, the number of cells under the study should be at least more than 100. So this is not a reliable study that contains only 65 cells in this diagram. So we have to study at least 100 cells per diagram or per study. Another thing is the coefficient of variation. As you can see here, it is around 39 or 40%, which is more than 30%. So this is a borderline or abnormal coefficient of variation, indicate that there is a polymegathism. And also the cell density here, it is okay, more than 2000 cells per square millimeter. So as far as the number, it's okay, but the quality and the qualitative assessment of these cells are abnormal. And also the index of hexagonality, which is 50% here, which is also borderline, should be more than 60%. So the overall printout, this is an abnormal, especially the number of cells under the study is less than 65, less than 100. So this is an need to be repeated. Now this test should be repeated again and study these parameters again. Now we reach to the nerve supply of the cornea. The nerve supply of the cornea, not only important because it provides the sensation for the cornea in the form of mechanical or thermal sensations, but also the nerve supply contribute to the proliferation of the cells and the release of certain neurotrophins and mediators that promote the cell proliferation and the epithelial proliferation. And the damage of the nerve supply to the cornea not only make the cornea insensitive to the pain or sensation, but also it will retard the healing of the epithelium and end up with disastrous outcomes if not managed early. So understanding the nerve supply of the cornea is very important. Now we'll speak about the nerve supply of the cornea, which is an important aspect on studying the anatomy of the cornea. Also, it is important from clinical point of view that there are many diseases of the cornea that affects the nerves, as well as the healing and the integrity of the surface epithelium, as well as the tear film is related to large extent to the integrity of the nerves of the cornea. Now, as you know, the cornea, one of the most heavily innervated structures in the body, and it is more sensitive than the skin by 300 to 600 times. And there are more than 7,000 nociceptors per square millimeter of the cornea. So the cornea is heavily innervated by nerve ending that service the temperature as well as the chemical stimulation, as well as the mechanical stimulation. So this is a very important structure that's heavily innervated, and this plays an important role in the integrity of the surface epithelium. Now, the corneal nerves not only serves to conduct the sensation from the surface of the cornea, but also it releases certain neurotrophic substances and neuropeptides that facilitate and act as a growth factor that is important in the regulation of the corneal epithelium and maintain the epithelial integrity. So in some diseases like neurotrophic keratitis, there is a persistent epithelial defect due to loss of innervation. So the nerve ending, they release certain growth-like factors and insulin-like growth factors that promotes the healing and maintain the intact surface epithelium. And the loss of the sensory innervation of the cornea can result in a vision-threatening clinical conditions like the neurotrophic keratitis, as I mentioned before. And now, recently, because of the advancement in the corneal surgery techniques, now scientists pay more attention to the aspect of the corneal innervation, as they found that it is very important in the healing process of the corneal epithelium, especially after LASIK procedures in which there is a flap creation, and the flap will be create a cut to the nerves. That's why they select the location of the hinge of the flap in the temporal or nasal side, which there is entrance of the nerve ending at that side to preserve as much as they can from the nerve fibers that enters to the cornea. Also, the healing of the in the keratoplasty cases in which there is 360 degrees cutting of the cornea, so the healing process of the cornea will be delayed because of the cutting of the nerves, and a time is needed for this nerve ending to regenerate, and that's why there is tendency towards the preservation of the cornea by doing the DALT procedure and other procedure other than penetrating keratoplasty. So the subject of corneal nerve ending is very important to maintain a healthy and normal cornea and to maintain the integrity of the epithelium, as well as the reflex tearing. As you know, the reflex tearing is related to the corneal sensation. So in order to have a normal tear response and normal tear constituents, intact nerve ending is very important. Another thing, the nerve ending plays a role in the protection of the eye. As you know, stimulation of the cornea is not just bring the reflex tearing, but also bring the blinking of the lids, and sometimes a blepharospasm will be there when there is any irritant condition to the cornea. So it is also plays a role in the protection of the cornea. In the next slides, we'll speak in the details about the source of the innervation of the eye and how they reach to the cornea and what are the different plexus that innervate the cornea. Now we'll speak about the nerve supply of the cornea, which comes mainly from the trigeminal nerve. As you know, the trigeminal nerve have three branches. That's the ophthalmic division, the mandibular division, and the maxillary division. The nerve supply of the cornea mainly comes from the ophthalmic division of the trigeminal nerve, and which in turn will be further divided into three branches. That's the frontal, nasociliary, and lacrimal nerve. Now the nasociliary nerve is the main supply of the cornea, and this nasociliary nerve through a short two long posterior ciliary nerves that bursts the sclera around the optic disc will supply the cornea. And also there is some innervation comes from the ciliary ganglia, which is mainly the autonomic innervations through the short posterior ciliary nerves, which are 5 to 10 in number. So the long posterior ciliary nerves, they pierces the sclera just around the optic nerve, and then it passes in the suprachoroidal space to be further penetrating the cornea just around the limbus. And at that, once they enter the cornea, they divide into three main plexus. That's the stromal plexus, occupying the mid part of the stroma, and the subepithelial, or also known as subbasal plexus, which runs between the basal layer of the epithelium and the Bowman's layer, and another intraepithelial plexus, which is tightly packed in the epithelial cells, where it ends up as a terminal intraepithelial free nerve ending. This is the main nerve supply. So once it enters the cornea, it enters through three plexus: the stromal plexus, subbasal plexus, and intraepithelial plexus. This is a brief description of the innervations and how the innervation reaches to the cornea. Now we reach to speak about the limbus. The limbus is a very important landmark of the eye, and it should be understood clearly the different types. That's the surgical limbus and the anatomical limbus and the surgical limbus, and the importance of the limbus for many aspects from surgical point of view to know as a surgeon where you make your incision and what's your plan, whether to enter to the anterior chamber or to the supraciliary space. So accordingly, you know at what level you should pierce the cornea or the limbus. Another thing, the limbus is very important because the healing process that happens for any injury or damage to the cornea is primarily guided from the stem cells which is present in the limbus. So understanding about the main histology of the limbus is also an important factor in understanding the healing process, and as well as in the management of different corneal defects that we will discuss later in the presence of persistent corneal defect or epithelial defect, or the use of certain surgeries like amniotic membrane transplant and so on. So let's dive deeply and go to the limbus.
Now, in the context of talking about the anatomy of the cornea, we should pay special attention and more detailed emphasis on the important structure of the cornea, which is the limbus. The limbus is not merely just a structure present in the eye, but it is a transitional zone between the cornea and the sclera. And the limbus is important landmark from a surgical point of view, and also it's very important to understand the role of limbus in the healing of the cornea, as well as in the different surgical procedures done within the eye. So the limbus make a transition between the cornea and the conjunctival epithelium, and also a transitional zone between the cornea and the sclera. And it measures around 1.2 millimeter. However, the size of the limbus is not fixed landmark, because the size of the limbus is related to the boundary made by the insertion of the conjunctiva. For example, if you can see here, this is the area of the gray area around the cornea, which is known as the limbus. And the insertion of the conjunctiva in the vertical meridian is more anteriorly. So the limbus is more broad in the anterior part, in the vertical meridians, as compared to the horizontal meridians, because of the anterior insertion of the conjunctiva in the vertical meridians. Now, what's the importance of the limbus? As I said, it is a very important demarcation between the clear and the opaque sclera, and it's important to understand the anatomy of the limbus to plan for the surgical incision that you want to do during cataract surgery, and to know the underlying structure that you might damage during your incision. So you should know the clear corneal incision, the anterior limbal incision, the high limbal incision, and so on. Also, the limbus contains the stem cells that's important in the cell cycle, as I spoken before, and the healing of the corneal abrasions and corneal ulcers. Also, the limbus provide nourishment for the peripheral cornea through the limbal vasculature. So the blood vessels in the cornea mainly present around the limbal area. And also it contains an important structure, which is the Schlemm's canal, which houses the scleral spur, and from the Schlemm's canal, the collecting channels of the aqueous will drain to the aqueous veins and the episcleral veins. So the Schlemm's canal is very important, especially in the glaucoma assessment. So all these are important points regarding the limbus, and we should know the detailed anatomical, surgical, and histological structure of the limbus. Now, if we look to the difference between the structure of the conjunctiva and the structure of the cornea, you can see that the conjunctiva is made up of stratified non-keratinized columnar epithelium sit on a substantia propria. However, the cornea, as we said before, that it is made up of 6 layers and mainly stratified non-keratinized squamous epithelium in a Bowman's membrane. So the main difference is that this is a columnar epithelium, and this is stratified squamous epithelium. Now, if you look to the limbal epithelium, it lacks the goblet cells and it contains non-epithelial cells with plenty of blood vessels, and they are between 8 to 10 layers. And if you look to this diagram, this represents the corneal epithelium, which is noted in the green color, and this is the conjunctival epithelium in the gray color, and the mauve color here, this is the transitional zone, that's the limbus, the transition between the corneal epithelium and the conjunctival epithelium. As I said, the transition from stratified columnar non-keratinized epithelium towards a stratified squamous non-keratinized epithelium, and the Bowman's membrane will terminate abruptly at the limbus, and it will fuses with the substantia propria of the conjunctiva. However, the remaining layers of the cornea will continue along with the sclera, and the Descemet's membrane will terminate in the Schwalb's line, and the endothelium will continue with the epithelium. The corneal endothelium will continue with the epithelium of the trabecular meshwork. So you can see this is the transitional zone, which is usually the conjunctiva or the epithelium arranged in a palisades known as palisades of Vogel's, and this is the main source for the stem cells that we explained before that contribute to the cell cycle and the repair of the corneal epithelium. Now, what's the histological limbus? This is known as the histological limbus. The corneal epithelium will continue with the conjunctival epithelium at this area, and the Bowman's membrane will become continuous with the substantia propria of the conjunctiva, and the corneal stroma will continue with the sclera. And the sclera, there is no sharp demarcation, but it is a wedge shape like this, and this is the scleral spur. And the Descemet's membrane will terminate in Schwalb's line here, and then the corneal endothelium will become continuous with the epithelium of the trabecular meshwork. This is what's known as the histological limbus and the transition between the corneal epithelium towards the conjunctival epithelium. Again, here I will repeat this point because it is very important. As I said, this is the structure of the cornea, and this is the Bowman's membrane, and it terminate at the limbus and continue with the substantia propria of the conjunctiva, as you can see here. This is the substantia propria, and this is the substantia propria in the blue color. This is the termination of the Bowman's membrane. Now, as far as the remaining parts of the cornea, the stroma, it will continue with the sclera. Sclera will not have a linear or sharp demarcation, but it will have a wedge shape with, this is the scleral spur here, which forms the scleral sulcus. This is the scleral sulcus, and it houses the Schlemm's canal and is covered by the trabecular meshwork here. So that this is the continuation of the corneal stroma will continue with the sclera. And then the corneal, the Descemet's membrane will terminate abruptly as a Schwalb's line, and the finally the corneal endothelium will continue with the epithelium that covers the trabecular meshwork. This is the exact transition between the cornea towards the conjunctiva as well as the sclera to constitute the histological limbus. This is the histological limbus. An important point that I would like to emphasize here before I leave this part, that normally the corneal endothelium during the gestational life is confluent with the trabecular epithelium, so that it forms a membrane that covers the angle of the anterior chamber. Normally, this membrane will retract and disintegrate before the delivery, and this makes the angle open and function properly. Now, for unknown reasons, in some situations, this membrane does not disappear, and this membrane has a contractile property, so it will obliterate the angle by making peripheral anterior synechia, and also creates holes in the iris because of the contraction, and lead to a secondary glaucoma. The same thing can happen also in post-trabeculoplasty and post-trauma, and this commonly seen in iridocorneal endothelial syndrome. In iridocorneal endothelial syndrome, it's a congenital problem in which this membrane does not disappear and lead to a secondary glaucoma due to this abnormality in the angle and due to the presence of this membrane.
Now, so the normal structure of the angle, if we see this diagram that represent, this is the cornea and this is the sclera, and this is the epithelium and this is the limbus. So that, as I said, that the angle is start by the termination of the Dismus membrane, that's at the Schwalb's line, and then this is the Schwalb's line, as I said. Then this is the trabecular meshwork and the Schlemm's canal. Then you will find this is the scleral spur. This is the part of the scleral spur that gives insertion for the ciliary body, especially the longitudinal fibers of the ciliary body. That's why when there is contraction of the ciliary body by drugs, this will lead to opening of the trabecular meshwork and the Schlemm's canal because of this action of the longitudinal fibers of the ciliary body on the scleral spur. Now, this longitudinal fibers of the ciliary body forms the ciliary band, which is seen on gonioscopy, and this is the iris root. This is the total structure of the angle, as you can see by gonioscopy, starting from the Schwalb's line and terminate by the iris root or the iris process. Now we come to an important definition, another definition, which is the anatomical limbus. We finished the histological limbus. Now we come to the what's known as the anatomical limbus, which is the area bounded anteriorly by a line, vertical line, or oblique line connecting the termination of the Bowman's membrane with the termination of the Dismus membrane, and posteriorly by a vertical line that's connect the scleral spur with the tangent on the surface of the sclera. So all this area is known as the anatomical limbus. Now this is very important to understand the exact boundary of this area, because in the next slides we'll speak about the surgical limbus and know the difference between the anatomical and surgical limbus from surgical point of view. Now this anatomical limbus, as I said, that it's around 1.5 millimeter from the surface, from the termination of the Bowman's membrane, and it is triangular in shape like this, bounded posteriorly by a vertical line and anteriorly by an oblique line connecting the termination of the Bowman's to the Dismus membrane. Now, as I said before, that the limbus is broader in the vertical meridians because of the anterior termination of the conjunctiva, and is narrower in the horizontal meridians and narrower in the 3 to 9 o'clock position. So it is more broader in the vertical meridians. Now we come to the important landmark, which is the surgical limbus. After we finish the histological limbus and the anatomical limbus, now we come to the surgical limbus. The surgical limbus is made up of 2 zones and 3 lines, the blue zone and the white zone, and 3 lines, the anterior limbal line and mid limbal line and posterior limbal line. So the anterior limbal line here denotes the termination of the Bowman's membrane, and this, as you can see here, this is the termination of the Bowman's membrane, and it is aligned the anterior border of the blue zone. Now this is called the blue zone, and the mid limbal line, which is midway between the anterior border line and the posterior limbal line, and it separates the blue zone from the gray zone, and it represents the termination of this Dismus membrane. So the anterior limbal line is the termination of the Bowman's membrane, middle limbal line is the termination of the Dismus membrane, and the posterior limbal line is the scleral spur, the termination or the landmark of the scleral spur. So this is very important to understand this, because in the next slides we'll explain about the clinical application and what are the structures that will be involved when we do the incision from the anterior limbal line or through the blue zone or through the white zone. Okay, this is the location of the scleral spur, and so this is the posterior limbal line. So we have 2 zones, the blue zone and the gray zone, and in between there is the anterior limbal line, middle limbal line, and posterior limbal line. In this slide, I will explain in details the different zones that we have explained before. The blue zone and the white zone, sometimes named as the white zone or the gray zone from surgical point. Now, the blue zone that extends from the termination of the Bowman's membrane up to the termination of the Descemet's membrane, as explained before. This is the area of the blue zone, and the white zone is the area from the termination of the Descemet's membrane up to the perpendicular line that's passing through the scleral spur. So this is the anterior limbal line or the anterior limbal border. That's the termination of the Bowman's membrane, and the middle limbal line is the termination of the Descemet's membrane, and the posterior limbal border, which represent the perpendicular line that passes through the scleral spur. So by understanding this picture, it is will be very easy to understand the different zones and the different incisions that passes through each one of these zones. In this slide, I will show the different zones that we have spoken. That's the blue zone and the white zone, sometimes named as the gray zone. Why this is named as the blue zone? Because as you can see here, the cornea is invaginated inside the sclera, and the sclera have like a fish mouth appearance that it over the transitional area, it is superior to the sclera, superior to the cornea, I mean. So the combination of this type of collagen arrangement, this is a regular collagen arrangement in the cornea, which is transparent, and this is the opaque sclera, gives the appearance of the blue color. That's why it is named as the blue zone, due to this invagination of the cornea inside the sclera. Now, this is the termination of the Bowman's membrane, limits the anterior border line, which is the anterior termination of the blue zone. And this is the termination of the Descemet's membrane, which is the mid-limbal line. That's the posterior end of the blue zone or the surgical limbus. And this is the scleral spur, as I said before. Now, the boundaries or the dimensions of the blue zone is superiorly is around 1 millimeter, and inferior is around 0.8 millimeter. So there is a difference between the thickness of the blue zone between superior and inferior part. However, in the horizontal meridian, it is nearly 0.4 millimeter, which is equal in both sides. Now we will come to an important clinical applications of the anatomy of the limbus and the relations between the limbal incisions and the structures that it passes through to reach to the anterior chamber. In the next slides, we will speak about the different zones and different locations of the incisions in relation to the different types of the landmarks in the limbus. Now, the anterior limbal incision, as the name implies, that we do the incision at the anterior border of the blue zone. Now, this is the blue zone that we have spoken before, and you know that the blue zone extends from the termination of the Bowman's layer up to the termination of the Descemet's layer. So this is the blue zone from the termination of the Bowman's layer here up to the termination of the Descemet's layer here. So if we make an incision in this one like this here, so the line will be passing through the termination of the Bowman's layer, and it will cut the Descemet's membrane. So this type of incision that you will enter to the anterior chamber directly, but there is a risk and a chance for inducing a Descemet's membrane detachment. Now, another point that if you do an incision anterior to the anterior limbal line here, so this is called clear corneal incision. Any incision beyond the anterior limbal line or the anterior limbal incision is known as clear corneal incision. Now, the second type of incision, that if we go more posteriorly, so we are at the midline limbal incision here, which is limiting the posterior surgical incision or the surgical limbus. So the incision here will pass through the end or the termination of the Descemet's membrane, as you can see here. So by this incision, you will enter to the anterior chamber directly, and you will pass through the termination of the Descemet's membrane. So there is no chance of inducing Descemet's membrane detachment, and you will be around 0.5 millimeter from the Schlemm's canal. This is the trabecular meshwork, and this is the Schlemm's canal. This is the scleral spur. So this is very safe incision if you do it at the end of the blue zone, which is the mid-limbal line incision. The third incision, that if we go more posteriorly here, so this is the posterior limbal incision, which is the posterior end of the white zone. Now, in this incision, if you go, it will pass through the scleral spur. So this type of incision, that you will not enter to the anterior chamber, but you will go to the supraciliary space. So if you go more posteriorly, that's at the posterior limbal incision, that's the posterior end of the white zone, you will not enter to the anterior chamber, but you will enter to the supraciliary space, because you are far posterior than the limits of the anterior chamber. The other type of incision, of course, if we go midway between the posterior limbal incision and the midline limbal incision, that's why in the middle of the white zone here, this is called white zone incision. Now, this white zone incision, as you know in the anatomy, that it will pass midway between the posterior limbal incision and the midline limbal incision here. So you will pass through the trabecular meshwork here. So you will induce damage to your trabecular meshwork. So this type of incision is not advised because you are damaging the trabecular meshwork. Now we will speak a few words about the pharmacokinetics of the cornea. By pharmacokinetics, I mean the mechanism of drug absorption and the corneal permeability, and the prerequisites for ideal penetration of the cornea, and what are the barriers that interfere with the absorption of the drugs, and also what are the different routes that we can bypass the barriers of the cornea, and we can reach to a high drug concentration within the eye after bypassing the corneal barrier. So few words we will speak about this pharmacokinetics of the cornea. Now when we speak about the pharmacokinetics of the cornea for the drug absorption, we will note that there are various barriers that determines the concentration of the drug within the eye. These barriers will interfere with the absorption and also interfere with the concentration of the drug. So we should take in consideration these factors to determine the drug absorption within the eye. Now, the first barrier is the tear film. Now, the tear film is important because it is a biphasic structure that contains lipid layer and mucus layer, and the substance that should able to penetrate through this layer should be able to both to dissolve in the lipid medium as well as in the aqueous medium. Also, the presence of the tear film will decrease the concentration of the drug within the tear film, and hence it will decrease the absorption rate through the cornea, especially if there is any obstacle to the drainage. So there will be excessive tears inside the eye. This will affect the drug concentration, or excessive drainage of the tear film will take with it the excess drug. So this will decrease the tear concentration as well. Another barrier, as you know, the 5 layers of the cornea, and the 5 layers, you have 2 layers are lipophilic, that's the epithelium and the endothelium, and the stroma is rich in the water, so it is an aqueous layer. So the drug should also be able to bypass these 2 different layers, the lipophilic layer and the hydrophilic layers. And as I said, that the normal tear film is around 7 to 10 microns, and the absence of blinking increase the tear volume to 30 microliters, and this will lead to decrease the concentration of the drug within the tear film. Also, if the tear film are excreted by high rate, so this will excrete with it the drug dissolved in the tear film. For any substance, an ideal substance that should able to bypass the tear film and the corneal layer should be has an amphiphilic substance. This amphiphilic character is meant that it is able to dissolve both in lipid media as well as in aqueous media. So a purely lipophilic substance will bypass, for example, the epithelium, but will be stuck in the epithelium because it will not be able to bypass the stroma, because the stroma is aqueous layer. And the reverse is true, is purely hydrophilic substance will not enter to the epithelium because the epithelium is mainly a lipophilic layer. So this point should be taken into consideration when we discuss about the pharmacokinetics of the drugs and the pharmacokinetics of the cornea. As I said before, that for an ideal substance to penetrate through the cornea, it should have an amphiphilic property. the amphiphilic property that they have a tendency to dissolve in a lipid medium as well as tendency to dissolve in an aqueous medium. Now, to measure the ability of any substance to dissolve in a lipid medium, that is determine the lipophilic affinity, they use what's known as the partition coefficient. They determine the partition coefficient and then they take the logarithm for that coefficient, and the value of that coefficient is representative for the lipophilic nature of this substance. Now, to do this test, they use the 1-octane fatty alcohol and use the water. The octane will, because the specific gravity is low as compared to the water, so it will be above the water. And they use the drug that they want to assess in this bottle, and it determine the proportion of the drug that's dissolved in the 1-octane in relation to that proportion that's dissolved in water. And accordingly, they measure the p-value. And then they take the logarithm for this p-value and determine the lipophilicity of the drug. So the partition coefficient defined as the ratio of the concentration of the unionized compound to that ratio of the same drug which is dissolved in organic medium, that's the 1-octane, to the same proportion that's dissolved in aqueous. Now, there are some factors that can increase the lipophilicity of the drug or increase the affinity for aqueous medium. For example, if we add the methyl group or the acetyl group to any substance, this will enhance the lipophilicity of that substance and increase the penetration, for example, to the cornea as well as to the blood-brain barrier if it is given systemically. However, the addition of the polar group, that's the alcohol or the OH group, this will increase the hydrosity or reduce the lipophilicity of that substance. So this, instead of being lipophilic, it will be hydrophilic. So by this way, we can manipulate the drugs or the drops that's given to the eye so that they increase the penetration through the cornea by adding certain groups to the drug so that it will increase its affinity based on the partition coefficient. If they found the partition coefficient is toward lipophilic drugs, so they want to increase the absorption through the cornea, so increase the alcohol group or the OH group. Because as I said that before, for a proper penetration to the cornea, you need a substance that has the two features, that's the ability to dissolve in lipid as well as the ability to dissolve in aqueous. Because we have the surface epithelium and the endothelium, they allow for the lipophilic substance to penetrate easily. However, for the stroma, which is mainly made up of water, so it needs a hydrophilic substance to penetrate. So a purely lipophilic substance will not penetrate totally, and a purely hydrophilic substance will not penetrate totally. So you need a combination of both. That's called the amphiphilic nature of that substance. Now, after we determine the partition coefficient, as I explained before, and we take the logarithm for that partition coefficient, the values are ranged between either to be a zero value or a negative value or a positive value. If the value is 0, it means that it is equally dissolved in both in lipid medium and in aqueous medium. And if it has a negative value, it means that the compound has affinity for aqueous medium, so it is a hydrophilic material. And if it has a positive value, so it has an affinity for liquid, for a lipid phases, and the compound is named as lipophilic. So a positive partition coefficient indicates that the substance is lipophilic. A negative partition coefficient indicates that the substance is hydrophilic, and a 0 value indicates that the substance is it has equal dissolve in both lipid medium and aqueous medium. This is how we interpret the meaning of the partition coefficient, as I show here that the lipophilicity on either side of the 0 value of the logarithm of the partition coefficient. In this diagram, I will show you for one molecule the relation between the corneal permeability in the y-axis and the partition coefficient in the x-axis. Of course, for the corneal permeability, there are many variables, including the molecular size of the molecules and the concentration of the drug and the pH factor and the tonicity and many other variables. But just now we are speaking about the partition coefficient in relation to a small molecule in relation to the corneal permeability. So in this experiment, they show that the best partition coefficient for best permeability of around 85% of the drug is permeable to the cornea to have a partition coefficient of 20. Partition coefficient of 20 means a logarithmic p-value of around 1.3 to 1.4, as you can see in this experiment. So this is one of the important variables that determines the corneal permeability is the partition coefficient. It reflects the amphiphilic nature of the drug that is should be able to bypass both through an aqueous medium as well as through a lipid medium. But this is not the only variable. We have other variables, as I said, that the drug concentrations, the pH of the drug, and the tonicity of the drug, and many other factors determine the final permeability of the drug through the cornea. Here are some of the examples of the factors that determines the permeability of the cornea, including the drug concentration and the solubility. As I said, the higher the concentration of the drug in the tear film, the more the penetration. Also, what's known as the viscosity of the drug, because the more the viscous the drug in a viscous medium, this will increase the contact time of the drug on the surface of the cornea, so that this will increase the penetration. And viscosity can be increased with methyl cellulose and polyvinyl alcohol. So when you find the preservatives and the media of the drug, that is the polyvinyl alcohol and methyl cellulose, this indicates this is a viscous media to increase the contact time of the drug with the corneal epithelium. Also, the lipid solubility, the more the lipid soluble, the more will be the penetration, especially from the epithelium. The epithelium needs an amphiphilic nature because the last layer of the tear film is the aqueous layer, that's the mucus layer. So it has to have an amphiphilic nature to bypass the epithelium, then the aqueous medium for the stroma, and then you need a lipophilic property to bypass the endothelium. Also, what's known as the transcellular pathway and paracellular pathway. Now, for small molecules that can bypass through the tight junctions between the cells, so they need a paracellular pathway that passes through the gap junctions between the cells. And for another molecules that can be absorbed by the cells itself and then excreted again from the cells, this is called transcellular pathway. The determinant of this pathway is the size of the molecule. The smaller the size of the molecules, the easy to be passed either through the paracellular pathway or through the transcellular pathway. Still in the context of the other variables that determines the corneal permeability is the surfactants, that's the preservatives placed within the drug to keep it sterile. They change the cell membrane of the cornea so that it increases the drug permeability. The presence of benzalkonium or thiomersal increases the permeability of the drug through the cornea. Also the pH now, the normal pH of the tear film is 7.4. Any deviation from this level will create some burning sensation in the eye, and this will lead to reflex tearing. And as you know, reflex tearing will decrease the concentration of the drug and decrease the permeability. So as long as the pH of the drug closer to the 7.4 will be suitable. Also the drug tonicity and the molecular weight, as we have spoken before, also all these are factors that determines the penetration. But the most common one and the most important one is the partition coefficient. When we look to the different way for the drug delivery to the eye, sometimes we use this way of delivery of the drug to the eye to bypass certain variables or certain barriers, that prevent the drug from being absorbed through the transcorneal pathway or through the transconjunctival pathway. So when you look to the mode of delivery of the drugs to the eye, we have a topical mode, that's the drops and the ointments and the gel. And we have the periocular mode as a subconjunctival injections or subtenon or peripulbar or retropulbar mode. Also, we have the intraocular injections as intracameral or intravitreal, or we have the systemic routes that's through oral or intravenous or intramuscular. Now, we utilize these routes sometimes to bypass certain variables. If the drug has a poor permeability through the cornea and we need a high drug concentration, we can give subconjunctival injections to bypass the barriers of the conjunctival epithelium, and we will have direct transscleral absorption. or we use a subcutaneous injection and so on. Sometimes the drug is not absorbed through the topical way. We need to give an intraocular injections or intracameral in the form of intracameral injection or intravitreal injection to bypass the barriers, and we guarantee a high concentration of the drug within the eye. This is another way to bypass the certain variables that prevent the drug permeability. By this level, we reach to the end of this lecture. I hope that you have benefited from this lecture, and looking forward to meet you in the lecture 2 regarding the infectious diseases of the cornea. And this is some of the references that I take from for this lecture, and also from the web. And for any clarifications or questions, you can contact me through the links below. Thank you very much, and looking forward to meet you soon.